Hey everyone, Joe back, and we are looking at lecture 1.6 for module 1 in RAD104. And in this lecture, I want to talk to you about the monitors that we use to show the fluoroscopy that we're doing. So we've talked about AM LCDs before, and so I don't want to spend too much time going over old material, but just as a refresher, these are active monitors, and so we can make all of these different adjustments, whether it be the brightness levels or contrast levels or different shades of gray, just by using buttons right on the monitor itself. So that makes it very easy for us to adjust the image, which is great. And don't forget that we've got liquid crystal displays. We have different pixels, and those pixels represent different areas on the image intensifier. They represent different parts or different areas on the charge coupled device that is being used. And so we're seeing the image as it is seen by that CCD, and which is really, really fascinating on how that works. But because it's a digital image, we're able to manipulate it and make changes to it. Now, this is most important when we're dealing with interventional radiology, where we use things like subtraction, and we use different things like inversion. The blacks become whites and the whites become blacks. And so we're able to do that. Not so much with regular diagnostic fluoroscopy. But all of this is possible because the image ends up being a digital image, and we can manipulate all of those pixels just by playing with the data. A couple of things to remember is that each pixel has an aperture ratio, which means that what you're seeing as far as light coming through each pixel is not the entire pixel, because we have to leave some room for a capacitor and a thin film transistor. Just like fill factor, don't forget that these monitors that we look at are very inefficient. We're only looking at 5% of the light that's created by the back of the monitor. So other than that, I think that's pretty much it. You can look over old material, but I don't think there's going to be many questions about the monitor that you see. But as long as you can remember that because everything is digital, we can change and manipulate the data, and we can make it do just about whatever we want. All right, with this slide, it's just a reminder that when we are looking at the monitor, we want to have a brightness level of about 100 lux. That is appropriate for stimulating the cone cells in our eyes, and those cone cells are for photopic vision, and they are used for viewing small objects and fine detail, which is your visual acuity. You need to remember these words. So having it, somewhat bright but not too bright. Obviously, when you do a fluoroscopy exam, you don't flip on all the lights and the room lights come on. You don't put on all those fluorescent lights. We usually keep it fairly dim. So you can either have a dimmer switch or you have the lights off, and the only light that you have on really is the TV monitor. I'm used to having kind of a dimly lit room. But you want to have it at the appropriate level so that not only are your cone cells stimulated to see the detail, but also maybe the rods are involved as well, and that can also help perceive some of the detail on the screen. So all of this is important, and all of this you need to remember for your test. Now, with regards to monitors, you may be thinking that when you use the C-arm, you have more than one monitor. But we don't have that when we're doing regular fluoroscopy in a regular fluoroscopy room. That's because usually in fluoroscopy, we're just kind of doing a procedure where we just see the here and now. We watch the person swallow the barium, and we perceive what's happening, and the doctor's going to make some mental notes on what they want to discuss in their report. But it's not like we're injecting contrast and we want to play it back again and play it back again, because it's not like we're intervening with our fluoroscopy room in diagnostic radiology. When we're dealing with the C-arm, or if we're dealing with interventional, then yeah, we might be intervening. So let's pretend in interventional we have a clogged popliteal artery in someone's leg. And so one of the issues might be when we introduce contrast that we see that blockage. Well, we might want to see that cine loop over and over again, and we can show that on one monitor. And on another monitor, maybe we can see the progress that we've made. Maybe we've injected a clot-busting drug, or maybe we have put in a stent, or maybe we actually just tried to push through that thrombus. So on one monitor, we can see what it was like, and on the next monitor, we can see the progress that we've made by doing some type of intervention. And so that's why there's two monitors with the C-arm and two monitors in the interventional suite. So we obviously don't need to do that in fluoroscopy when we're doing an upper GI. So, but it's kind of nice to have those two monitors, and we're able to play cine loops over and over again. And it's up to the technologist to know how to use this hardware so that they can assist the radiologist or the surgeon, whoever is doing the procedure. Another reason for having two monitors is maybe we've seen with just doing hip x-rays, maybe on one image you can see the AP, and the other one you can see the lateral, and the doctor can kind of compare the two. That's another good reason to do it. Maybe one image is irregular viewed and the other one might be either subtracted or maybe inverted, and they can compare the two. But the two images are nice because you can compare one with the other, whether it be just a time factor. This one was taken, a half an hour before the intervention. This is what it's looking currently. This is what it looks like currently after the intervention. Or just maybe, here was the break. Now here is it after fixation, and we see that we've taken the break and put it together. So whatever the reason is, the two monitors are very, very helpful for several different reasons. I did just want to point out digital subtraction, which is a big thing with interventional. And so when you see contrast in somebody's vein, we're dealing with interventional. And this is not only a nice example of digital subtraction, but it's also a nice example of inversion. So you can see we've got a femur, okay, and you really have trouble seeing the vasculature. I mean, now that you see this, it's kind of easy to find it right here. So we've injected the contrast, and we can see it coming through the lumen of that vessel, which is great, and then we can take a still shot. But then what we're going to do is we're going to subtract the bone. We don't want to see this bone anymore. Now, it doesn't completely go away. The software does its best to kind of match up everything with the same shade of gray, but you can still almost see like an outlining of the bone. But nevertheless, to the eye, you don't have to worry about this area here. The shades of gray of the bone kind of match the shades of gray of the vessel itself. So if we take that bone away with subtraction, which they've done here, even though you can still see the outline of the bone, it's still a little bit easier to see what's going on right here as opposed to right here. So this is kind of nice. And then if you want to invert it, then you might be able to see a little bit better or some more detail. Depends on who you are and your eyes and your training. Maybe some people see more detail with this, some people see better or more detail with that. So, but that's a nice example of digital subtraction, of taking out that femur as well as inverting the image to something like that. And when you think about it, and I just kind of caught myself when I was ending that last segment, this really here is more of what you would see, because don't forget, contrast is preventing X-ray from hitting the plate or hitting the image intensifier. And so when something does not hit the image intensifier, it's white or light gray. So that's what it would actually look like. And then we invert it. So whenever we do fluoroscopy, we see the barium go down a person's esophagus as a black globule or bolus of contrast. Well, that's already inverted, because if it was absorbing all of that X-ray, it would be white, right? So just thought I'd point that out to you. And I thought I would show you this cine loop. I've got this, it's actually in the PowerPoint, and if you double click on the link, it should open up to this cine loop. It's actually a very quick cine loop. It's only for like 14 seconds. But this is something that your C-arm can capture, and you can visualize it over and over, just like what it's doing. And you can tell it to loop itself. So if you're a doctor and you want to see your progress, or you want to see what's happened, and just keep watching it over and over just to see if there's any other place that needs to be worked on, any other place that, before you close up the case, maybe just make sure everything is looking okay. Having a cine loop available and you're able to watch it over and over again is very, very helpful. So instead of hitting the person with additional X-ray, you can just record what you have done and then watch it over and over again. So this is, again, more of an interventional thing, but still part of fluoroscopy, and one of the great ways of utilizing this technology to help patient care, which is great. All right, guys, and with that, I'm going to stop here. So kind of a recap of some of the stuff we've already talked about, whether it be last semester or earlier in this lecture, and just some of the examples of some of the work that we can do with the data we receive in digital fluoroscopy, which is pretty fascinating stuff. So if you have any questions about this, let me know. Otherwise, I'll see you at the next video. And I'm hoping to wrap up with just one more, but we'll see. All right, see ya.